Welcome to this overview on the management of hepatobiliary disorders, an essential aspect of surgical practice you'll encounter both in general surgery and specialist hepatobiliary units. In this session, we'll briefly highlight the key principles involved in managing benign and malignant conditions affecting the liver, pancreas, gallbladder, and biliary tree. Let's start with benign hepatobiliary conditions, focusing on gallstone disease and acute pancreatitis, two of the most common presentations in clinical practice. Gallstone disease is highly prevalent and can manifest in various forms. The most common presentation is biliary colic, which occurs when a stone intermittently obstructs the cystic duct, causing episodic right upper quadrant pain. However, complications arise when stones become lodged in more critical locations. Acute cholecystitis occurs when the gallbladder becomes inflamed due to prolonged obstruction of the cystic duct. Management typically involves IV antibiotics and early laparoscopic cholecystectomy. Delaying surgery increases the risk of complications like perforation. Choledocholithiasis, or gallstones in the common bile duct, may present with jaundice and is associated with the risk of acute cholangitis, an infection of the biliary tree. This can quickly progress to sepsis, making early recognition and treatment critical. The management typically involves ERCP to remove the stone and decompress the biliary system, followed by interval cholecystectomy if indicated. In some cases, gallstones can trigger acute pancreatitis when a stone transiently obstructs the pancreatic duct. Managing gallstone-induced pancreatitis involves not only treating the pancreatitis but also definitive gallbladder removal to prevent recurrence. Acute pancreatitis management involves primarily supportive care with aggressive fluid resuscitation, analgesia, and close monitoring for complications. Most cases are self-limiting, but severe pancreatitis may require intensive care and interventions like percutaneous drainage or surgery for infected necrosis. Identifying and addressing the underlying cause, such as gallstones or chronic alcohol use, is crucial to prevent future episodes. On the malignant spectrum, we focus on two common entities: hepatocellular carcinoma, also known as HCC, and pancreatic head carcinoma. Hepatocellular carcinoma, commonly seen in patients with chronic liver disease, particularly cirrhosis from hepatitis B or C, and alcoholic liver disease, has variable treatment approaches based on tumor staging and liver function. Early-stage disease is treated with surgical resection or liver transplantation, while advanced cases may benefit from transarterial chemoembolization, or TACE, or newer systemic therapies like tyrosine kinase inhibitors. Carcinoma of the head of the pancreas often presents late due to its silent progression. When diagnosed at an operable stage, the Whipple procedure, also known as pancreaticoduodenectomy, offers the best chance for cure. However, many patients present with advanced disease and require palliative measures like biliary stenting to relieve jaundice and chemotherapy to control tumor progression. Effective management of hepatobiliary disorders requires a multidisciplinary approach, timely intervention, and the ability to tailor management based on disease severity, whether it's surgical, endoscopic, or palliative. In your clinical practice, you'll need to integrate these principles to ensure optimal care for your patients. Thank you for watching, and we'll explore these topics in greater depth in the upcoming sessions.